Okay, everybody, thanks for joining. I think we're going to go ahead and get started. I'll
Okay.
let you introduce.
Today we have Dr. Kyle Myers with us. So he was a resident at KU. He graduated about 5 years ago, did a chief year, went to Vanderbilt for his training, and then thankfully made his way back to us so that we can pester him for things like this. He's core faculty with the residency. He does a ton, he wears a ton of hats, and we're very thankful to have him for this. So it's labeled as endocrine potpourri, but I'll be honest, we're mostly going to focus on hyperaldosteronism, essentially exclusively, because as I was making this, I thought we would also talk about minimal autonomous cortisol secretion. And I was like, I think that that's just too much, and there's probably plenty here to just do hyperaldo by itself, especially since there's so much more of an emphasis on it. For everyone, there's a slightly new feature where you're going to be able to post a question in the chat, and then people will be able to upvote it. So it's in the Q&A section. If you do that, and then we can kind of prioritize our questions and how they get answered kind of closer to the end based on the popularity of the question. It's the same thing that ACP does. We will jump in. This is just like a standard, very standard case. And we'll kind of just see Dr. Myers' rationale and thinking through this patient who presents with resistant hypertension. So this is a 52-year-old male patient, or a female patient, BMI of 32. She comes to her pre-PCP with blood pressures of 162/98, despite being on amlodipine 10, lisinopril 40, and hydrochlorothiazide 25. She has type 2 diabetes, obstructive sleep apnea, compliant with her CPAP, and she has a potassium of 3.6 on her BNP. She says she takes all of her medications. You screened her for noncompliance. It's not that. And she follows a low sodium diet. She tries to do all the right things. One of the biggest things I think that we have seen be emphasized more in the last year from the Endocrine Society as well as ACC and AHA with the new hypertension guidelines is early testing for renin-aldo. Dr. Myers, do you have any opinion on that rationale for us kind of switching our mindset from these really high risk patients to a more generalized approach to evaluating?
Yeah, I think this patient, for instance, I mean, she's got a lot of metabolic sequelae already, sleep apnea, she's obese. She kind of fits the prototypical high risk patient that we would consider to screen. And I think traditionally that's always been, if they're hypokalemic and they're resistant hypertension, or if you have an adrenal incidentoloma that you found, those are the patients who would get screened. But, as John is saying, recently we've really relaxed the criteria for that. The 2025 Endocrine Society guidelines actually suggest that really anybody, any adults with hypertension, you should consider screening for primary aldo in. And I think that's a good thing. I think as long as you understand the nuance of the testing, which I think we'll get into in a little bit, and really kind of understanding that there's a lot of fluidity. It's kind of like checking your cortisol, a random cortisol in the day, right? Like there's going to be some lability and variability in the renin and aldo testing. And so if you get really a negative screen initially, don't necessarily discount this patient from having primary aldo, especially if your clinical suspicion is a little bit higher. So to kind of answer your question, John, I think it's good that we're broadening the screening criteria and really relaxing and stressing that more patients should be screened. We do know that uncontrolled hyperaldosteronism does carry a lot of cardiovascular risk, premature mortality, heart attack, stroke, heart failure, a lot of pretty serious comorbidities associated with uncontrolled hyperaldosteronism. So,
Dr. Meyer, can I dive in a little bit more into the why? So, why is it so important to identify this? Like, why can't I just try a little spironolactone and if their blood pressure gets better? And often this not uncommonly it does, right? We presume that they're a little bit of hyperaldo if they had a disproportionate response to an aldosterone kind of directed medication. Why? Like, what's so bad about this hyperaldo if we could treat it with something simple as like spironolactone or Clarinone or something?
yeah, I think that's a fantastic question too. I would say primarily you want to, because surgical, unilateral adrenalectomy is still a very viable treatment and saves the patient from lifelong medication. The medical therapy for hyperaldosteronism is lifelong mineralocorticoid receptor antagonism. which carries its risk of electrolyte disturbances, other side effects too. Patients' compliance always becomes an issue. So I think the low-hanging fruit is to use the medication. But I think in reality, if you're thinking about several decades of therapy, for instance, or someone who already has pill burden that's pretty high, if were able to think about a surgical option, I think that would be at least worth the discussion with the patient. Um, I think there are some patients maybe who are extremely complex. You think surgery is never going to be an option for them. I think it's super reasonable to just go ahead and try medical therapy and kind of save yourself, suppression testing, and the nuance of trying to distinguish and interpret those results too. I think there's a lot of ease with just trying medication therapy. But for, if there's any question of whether the patient would want surgery and benefit from surgery and could save them from lifelong medication, I think doing the formal workup is recommended. Yeah.
Yeah. Okay. That's helpful. And that's kind of how my practice has evolved, actually. Whereas, like, we were talking a lot about this when Jordy Cohen came a couple of different times out of Penn, and she's kind of has done several studies on hyperaldo. And I was screening everybody, and I got like one person to the point that there was a nodule on one thing on one adrenal gland, and I did the testing, and it was bilateral. So at the end of the day,
Yeah.
I've basically just always treated everybody with spironolactone, and I've kind of moved on. And then I've just kind of gotten lazy with screening on it because I've just never really, I haven't really seen the clinical value of it, to be honest with you.
Yeah.
It's so that's helpful. So I think really the summary, and you think surgery might be an option for this patient. You don't want them on lifelong medications, then we should be screening them.
Yeah, no, I
You
think,
have thoughts?
well, my thing is like, I love the universal screening because like you're not messing around with blood pressure. You're not waiting to screen until, it's 5 or 10 years down the road and you're like not doing a great job of controlling. They're always coming back and you're always ramping up medications. Plus, like, we'll talk about the diagnostics, like when you're on medical therapy is just like feels so much more complicated. So I just love like jumping in early, finding those people as soon as possible that even if they have bilateral, aldosteronism, like it's still nice to know that they have that because you could do Spiro and get away with maybe discontinuing some of their other medications in that case, which is now how I kind of use it. But
Yeah.
And then they
I
get
also think,
diagnosed, yeah.
yeah,
Then they love me.
I was a player.
Yeah.
yeah, I think it's important to, for the patient to understand that this isn't really run-of-the-mill hypertension too.
Mm.
And I think if you've somewhat established the more formal diagnosis, or at least had the conversation of spironolactone as specifically treating a unique endocrine hypertension that has, a higher risk of cardiovascular complication, that adds a little bit of, severity and compliance, I think, maybe to the medication than the patient think, well, it's just one of my blood pressure medications, and some days I get it and some days I don't. Whereas if they know that they've got this, unique clinical entity, um, I would like to think maybe they would take that a little more seriously too. And I think, to kind of Dr. Comfort's earlier point, definitely the younger the patient, the more severe the hypertension, the younger the patient with hypokalemia, that's definitely absolutely the patient where you would probably want to go through the more formal workup because you're more likely to find success in surgical management for those patients, typically.
You've mentioned this a couple of times, but the mortality, the cardiovascular kind of morbidity associated with hyperaldo. So is it disproportionately high compared to other causes of secondary hypertension that might cause a similar rise in blood pressure? Is that, or are you just talking about secondary causes of hypertension in general?
So hyperaldosteronism specifically
Yeah.
carries unique cardiovascular risk in addition to primary hypertension. I don't have the statistics right in
Yeah.
front of me, John. I probably should have brought
No,
that
no.
for you. But I think that's why the discussion and conversation around this diagnosis is important, and not just empirically trying medical therapy, is because there's a much higher incidence of stroke, heart failure, heart attack in patients with primary aldo that's untreated. So,
Okay.
Yeah.
So sorry, John, should we have them using the Q&A, right?
So let's,
Okay.
yeah.
So yeah, love the chat questions, guys. We love the participation. It is confusing. Please use the Q&A tab down below, because I think if you missed John's earlier preamble on this, that this is similar to how ACP does it, where the Q&A will allow us to upload it. Well, Q's is only host to be able to see it. Oh, is that okay?
That sounds good.
I
Okay.
can
Well, there's always a wrinkle, Bree. Okay, thanks. On the fly here, trying something new. This is what we get. Okay, maybe put it in both then, if you don't mind. So,
Um,
uh,
okay, all right. So let's jump in and get into a little bit of the nuance. So we decide for her, like we said this is a great patient to screen for hyperaldo. So we order our renin aldosterone. What do you tell them before they go down? Like, what are you looking at? Are you making sure their blood pressure is controlled before they go get it done? Are you making sure hypokalemia is controlled? Are you having them stand for a certain amount of time? Like, what's your kind of instructions for the patient before we get formal testing?
Yeah, I think this brings up, there's a lot of nuance to this. So we'll kind of take it one by one. In terms of, current blood pressure control, I'm not necessarily looking for, a blood pressure target before testing, but of course it's important to know kind of what their medication list is. There's been a lot of, I think, with the increased, recognition of screening for PA, I think has also come this acceptance that we really don't need to pull patients off a lot of their medications. Even the MRAs, if they're on spironolactone already and they're already down in lab, as long as you get an 8 a.m. testing, kind of supine testing, the patient's technically supposed to have been resting for about 15 to 20 minutes, then go ahead and grab your renin and aldo. And if you have a suppressed renin, then that's highly suspicious for PA. If you're on a medication that is going to raise your renin levels, so an ACE, an ARB, an MRA, and you draw your testing on medication and the renin is suppressed, that's highly suspicious. Um, so I think, definitely if they're on an ACE inhibitor, if they're on an ARB, we don't ask patients to pull those medications off because then you kind of get in the trouble of, well, I've got to, you know, get them on a, maybe a calcium channel, some other alternative therapy to control their blood pressures. I don't want them going crazy uncontrolled. It gets confusing for the patient. And you might catch a suppressed renin while they're on their medications. So having that kind of found, a little bit of basic knowledge of how the different antihypertensives will affect the renin levels is helpful. So ACEs, ARBs, of course, your spironolactone, the eplerenone, the ENaC channel inhibitors, triamterene, those types of medications will raise renin levels through the renin-angiotensin-aldosterone feedback system. Calcium channel blockers, the alpha 2 blockers, clonidine, are known to suppress renin. So if you check those levels and you have a suppressed renin, they're on a beta blocker, then you may want to consider having them come off therapy. So just kind of, take a picture, find that there's a lot of good charts out there. Up to Date has a good chart, Endocrine Society, on how the different medication classes will affect the renin levels. So maybe just snap a picture of that, always have it on your phone. So, when you're interpreting those results, you have a quick resource to kind of say, okay, is this expected? Is this unexpected? Do we need to have the patient come off the medications? Um, the only thing from an electrolyte perspective is nice is to normalize serum potassium levels because hypokalemia will lower aldosterone. So that may cause some um, false negative testing if your aldosterone is low, but they're already hypokalemic. So in that case, I would supplement with potassium to try and normalize that before. Obviously, you may not know that if you know, um, you don't have that baseline BMP or something, but a lot of our patients on diuretics, maybe their potassium's already a little bit low. Keep that in mind that you do want to try and achieve normal kalemia before you do this testing.
But that's another one of those situations where you're talking about like if they're hypokalemic and you check in and their renin is suppressed, it's even more suggestive.
Right. Like you could check your labs, the potassium's low, renin suppressed, aldo is high. Then, that's pretty clear cut. That's highly suspicious for PA.
Okay.
But if you get something with a low potassium and your aldo's 12, 15, renin's kind of low, there's some indeterminate results, then it's probably worth having the patient supplement and repeat testing. Yeah.
is there a level you're looking for there, Kyle? Like, we have all these patients who's it's like 3.6 or something. Is that good enough, or do we need when you say replaced on the potassium? Is that what level are we looking at there?
Yeah, I usually, like a 3.4 or higher, like anything that's kind of frankly low, I would be concerned about. So like, a 3, 3.2, 3.3, I probably would.
And that's
Um,
enough to suppress aldose secretion,
yeah,
right?
especially if you're
That's
getting
what we're trying to do to prevent the feedback on that.
exactly. Yep.
Okay.
Yeah. So hypokalemia is lowering aldosterone production. And so really, if you have any kind of low potassium and your aldo results are indeterminate, your renin's indeterminate, go ahead and replace. and definitely try and shoot for a normal range on the lab assay, which I think for us is 3.5, right?
Yeah, somewhere in there.
Yeah.
What do you do? I feel like a lot of times I do this. So this has been a frame shift for those of us 40 and over. We were basically told to stop all aces and arbs when we
Yeah.
were doing this, and that has shifted. And when I have done this, I feel like I get a lot of these kind of mid range run-ins and stuff. I'm not really sure how to. It's easy if it's like suppressed, right? But if can you walk us through some of the details on that, I guess? Like, what levels are you like satisfied? Like, yep, that's suppressed. Or, yeah, okay, we really do need to have pause their meds for a bit and reassess this. Like, can you kind of share a couple of details there?
Yeah. So I think, the really the whole cornerstone of PA as a physiologic diagnosis is autonomous aldosterone production. And so you're really trying to see what you will see is abnormally elevated aldosterone in proportion to a low or suppressed renin level. And so a lot of people will say the ratio has become less significant. What you're
Mm.
looking at is the renin low. And if the renin's suppressed and if the aldosterone, our lab uses what also is confusing is, there's, immunoassay labs, there's mass spectrometry labs. We have an immunoassay lab. So if you see an aldosterone of, that's really over 15, um, and the renin is low or suppressed, that's suspicious. If you have some indeterminate labs, if the renin's not entirely suppressed, that's where the ratio is more helpful. But if you see a suppressed renin and your aldosterone really is, over 12 to 15, that's highly suspicious for PA. Yeah.
That's so nice to hear because we get like these less than 3, for the Renin, but the Aldo's 8. I'm like, well, technically the Aldo's, yeah, it's just
Yeah, if the aldo is less than 10 and the renin is suppressed, I think that's a patient I probably would repeat testing on. That
okay.
kind of hark, especially if your clinical suspicion's a little bit higher. Maybe they've got resistant hypertension, they have family history, they're hypokalemic, they have adrenal incidentaloma and hypertension. I definitely repeat testing because of that kind of fluidity and these hormone levels.
And so you
Um,
repeat it, right? Like, you don't change anything. You're still not having whole damn amlodipine or something, right? You're saying, okay, just go back to the lab, make sure you're supine.
What is it? Can
yeah,
we talk? Can we
Yeah,
exactly describe what that means? I mean, like, I've read that before and I still don't. I just tell people, let's just go get it done. I don't know how to counsel them on that.
supine or seated, I think seated is fine too. You just essentially you don't want any postural effects from a hemodynamic perspective interfering with these lab results. So ideally, the patient's been seated, they're resting for at least 10, 20 minutes. It's an 8 a.m. test. There is a very, there's mild influence of mineralocorticoid production by ACTH. So obviously, this is a primarily ACTH independent process, but we still like to get 8 a.m. testing. And then the positioning of the patient's important too. You don't want to have them, standing and then laying, and then, it's not like orthostatics. You're trying to really exclude postural implications here. Um, and yeah, so I would, if I get some indeterminate lab results, I would have the patient come back a week later. Assuming the potassium's normal, I wouldn't change medications. Yeah.
okay. Okay. Well, let's see. We're 23 minutes in, and John and I still aren't satisfied with just the Renin test, I guess. But let's get to we have a couple of questions in the chat here that we'll throw towards you. So, in someone with confirmed primary hyperaldo under medical therapy, no surgery, is there benefit to maximizing the MRA dose? If they're on Spiro and another agent, is there reason to titrate up on the Spiro and down on the other agent, assuming their BP is that goal on both?
Spiro and another agent. Yeah, I think that's a great question too. I think the general consensus is if their blood pressure is normal, and they're on multiple agents, you could try and up titrate the MRA and down on. Obviously, the more we can simplify medication regimens, the better. And I think for definitely if there's more significant PA, you'll find that you'll be able to peel off a lot of these other, antihypertensives with good MRA therapy. If someone has uncontrolled blood pressure, then on MRA therapy, then we tend to increase spironolactone essentially to try and raise renin to above a baseline level. So either you had a suppressed renin level at diagnosis, or maybe it was low, and you can kind of titrate the spironolactone to see if you can actually get that renin level raised. So we will check that, and in terms of monitoring therapy with the electrolytes too. So
Okay, great. Let's see. There's one about, does it matter if their blood pressure is controlled or not before screening for primary hyperaldo?
Yeah, I don't typically worry as much about what their baseline blood pressures are. Yeah. Um, I think the biggest thing is kind of getting a serum potassium, making sure you're looking at the coexisting medications they're taking to know how those are going to affect the lab results too. So, yeah.
And then we have another question about how if phlebotomy or if our lab kind of knows if we put in a Renin-Aldo, do you have any idea if they're trained to have the patient sit for 15 minutes before they draw that?
I think it's highly unlikely that they're
Yeah,
aware.
same. Okay.
So
So how do
always
we get
keep in
that
mind.
done? We put a comment or we just tell the patient or what?
Yeah.
How do
Usually I talk with the patient about that. When you're saying, what to expect with testing, you want 8 a.m. testing, we're going to want this, kind of seated, resting, try and make sure they don't rush you in there. And, you went from standing to sitting and blood draw immediately. And technically, I think, you know, I was even told, or at one time in fellowship, that really, you're not, when you have the tourniquet, you release the tourniquet and then let blood flow for, about 30 seconds to 60 seconds before you actually draw the venipuncture lab. So you're really trying to exclude anything that might interfere, with the potassium or with those Renin-Aldo labs. So yeah, to answer the question, I mean, I think it's super difficult. That's one of the things that makes this kind of just a frustrating entity to diagnose.
Yeah, this is why I stopped screening, guys.
Yep.
It's too complicated. All right. Should we move on,
Well,
John? Yeah.
so we got hers back, and the Renin is less than 3, like we talked about, and her Aldo, we'll say, because you kind of already answered this in a different way, but her Aldo is 14. And so you kind of mentioned 15 is your cutoff, and it's so on a spectrum. It sounds like it's not super defined. And I listened to a podcast, and they're basically like, we just had to draw a line in the sand somewhere, but all these exist on a spectrum. So would you feel comfortable saying, with an Aldo of 14, like you have primary hypoaldo, and we should march down the path of figuring out what it is, where it's coming from
For this patient, John.
for this patient?
Yeah, I would definitely go down the path. Yeah.
Okay.
Yeah. I mean, clinically the picture fits. Um, the aldo's kind of in an indeterminate area. Renin suppressed, absolutely.
And
Oh, wait,
there's
that was
yeah,
sorry. On her initial testing, was Renin suppressed?
Renin suppressed. Yeah, Renin less
Oh,
than 3.
absolutely.
Yeah, yeah. Okay.
Yeah. An aldo over 10 with a suppressed Renin, suspicious.
Over 10 with suppressed Renin. Okay.
Can we
Uh,
diagnose it right there? Or do we need the other test?
I think that kind of is the clinical, like, where do you see the treatment going for this patient? If she's willing
Yeah.
for surgery, if you think surgery is even an option, I would definitely proceed with suppression testing and imaging. But if this patient would never want surgery, or maybe they have heart failure, you're going to put them on spironolactone anyway, you probably could stop right here.
Yeah.
Yeah.
Are we talking about
we're going to
suppression
talk
tests?
about suppression
Okay.
testing. Is there a point with the Renin Aldo levels where you say you probably don't need suppression testing? We can just move forward. Is there an Aldo with a suppressed Renin that you look at and you're like, this is pretty slam dunk?
Yeah, it's more so kind of the clinical picture too.
Okay.
If someone does, if it's a young patient, they're, 20, 25, 30 years old, they have hypokalemia, that they have a unilateral adrenal adenoma. I mean, I would go straight to, you know, I would skip suppression testing. Yeah. But the older the patient is, the more indeterminate the results. If surgery is an option at all, always do suppression testing.
Yeah.
And so there's of course a million different ways that these tests can come back. Something that I've seen a lot of is, and just to help us with interpretation of when all these come back, because if we screen as much as all these organizations want us to screen, we're going to see a whole host of things and we're just going to get so confused. So starting with like the one that I think that I see the most is whenever I test it, their renin will be super high and their aldo's kind of in a whatever range, but their renin, is high or normal at least. And their uncontrolled secondary hypertension, what do you make of those patients? Obviously not primary hyperaldo appearing, but like what causes that?
Well, if it kind of again harkens back to the clinical suspicion. Is
Yeah.
this patient on an ACE and ARB? Are they on an MRA already and the renin is high? Well, then you're probably going to have to think about pulling them off therapy and repeat testing. Um, if this is more just, if we're broadening our screening criteria as the guidelines would hope that we do, and now you've got a patient who's borderline controlled on one, amlodipine, for instance, and renin's high, you've pretty much excluded PA.
Okay, sounds good. So that's just one of the other many causes of secondary hypertension. Like you are getting just an inappropriate renin secretion. That's why your blood pressure is high, I'm assuming.
Yeah, yeah. You mean if you see the renin's high?
Yeah, yeah, yeah. Okay. Okay. So then, and then we kind of talked about these borderline levels and the high levels, like the slam dunk cases. But let's talk. The challenge testing is something that I feel like we're probably pretty uncomfortable with. So, what's the patient where you're having them come in and you're doing the challenge testing? Like, what does that patient look like to you?
That's, I think first is the patient, is surgery an option for this patient? Would they desire it? Are they a surgical candidate? If yes, then kind of what is your likelihood of being able to lateralize? If you think kind of what is the chance of us finding a unilateral adenoma or, bilateral nodules that you're able to lateralize something with? And that kind of goes back to the severity of the PA, the hyperaldosteronism, the presence of hypokalemia, the higher the aldo, the more suppressed the renin, those types of things. So if you think that there's, a higher or even intermediate probability of that, so the more severe the hypertension, the more abnormal the labs, then I would go ahead and do suppression testing if you think surgery is an option for this patient. If surgery is never an option for this patient, don't put yourself or the patient through that unnecessary testing. You're just going to go straight to medical therapy if that's something you decide to do. Um, so that's, there's a few different ways to do the suppression testing. So again, what you're trying to test in endocrine, of course, we love our feedback loops. You're trying to salt and fluid load the patient so that, or essentially test that negative feedback from the renin angiotensin aldosterone system. You can do that in a few different ways. I think most of our practice is to simplify it as much as possible, do an outpatient ambulatory test, suppression test by having the patient salt load 4 to 5 grams of sodium, either through diet or salt tablets. Um, Pretty much we're always doing salt tablets for these patients in addition to a high salt diet. You do that for about 3 to 4 days. And then on the last day of the testing, have the patient start and complete a 24-hour urine collection for sodium and aldosterone and creatinine. And you're essentially trying to see, okay, with the sodium, did I salt load the patient enough? The creatinine is saying, okay, do we get an adequate urine specimen? And the aldosterone being appropriately suppressed would exclude PA. Because again, if you're salt and fluid loading somebody in a typical feedback, you're suppressing renin, suppressing angiotensin, and suppressing aldosterone production. So now always make sure the patient's potassium is normal for any of this testing too. Um, so that's, the other way to saline suppression test somebody is by giving them IV saline. So you check baseline labs, infuse, about 2,000 mils, 2 liters of normal saline, and then repeat your aldosterone testing too. And again, what you're looking at mainly there is a suppressed aldosterone has excluded your PA. What's difficult about the suppression testing is there's not a lot of good agreed upon cutoffs for these tests. So that makes it even more difficult too. But what is nice is if you do suppress, then you've excluded and you don't need to, grab a CT. You wouldn't want to do ABS, those types of things.
I think the nice part about this is that when you finish salt loading them, all of our patients with diastolic dysfunction will get admitted with heart failure, and then we can just get the CT right then.
Yeah,
if it comes
that sounds like a risky idea.
You
How
could
much
you
does
could
it have
cap
to
the
be
pearl challenge.
suppressed?
Yeah,
Like,
sorry, Brandon, go ahead.
yeah, what the like? So yeah, I always need like trying to get a little more concrete because I start to do this and then I get caught because I don't understand the magnitude of suppression, right? Like if it goes from 15 to 13, is that suppressing it, or does it need to go down to less than 5 or something on the Aldo, or like what is there criteria, I guess? Someone,
Yeah, there are, and that's yeah. So the recent, the 2025 Endocrine Society guidelines have recommended cutoffs for what would exclude PA. I actually have them right in front of me here because I knew that would probably come up. So, for instance, on the 24-hour urine collection, after you've salt loaded somebody at home, 24-hour urine aldo less than 10 micrograms per nanomoles per 24 hours makes PA highly unlikely. And there's cutoffs too. The difficulty comes too when you get the indeterminate results. But we do have specific cutoffs for those suppression tests that essentially say you can confidently exclude PA, and that's what you're trying to do here. Again, it's not necessarily a diagnostic tool, but it's a confirmatory test in addition to the screening test. So,
Gotcha. Okay, sorry, you said under 10. Once it gets under 10.
yeah, yep.
Yeah. Okay, so it's not
Um,
necessarily a change in the aldo, but if the aldo gets under 10 after appropriately loading them up with salt, that would be pretty unlikely to be a primary hyperaldosteronism.
yeah. Or
All right.
for instance, on the saline suppression test, the guidelines say if you can get the plasma aldo under 7.8. So say,
Seven.
yeah,
I'll
yeah,
remember
the
that.
urine testing has a little bit different kind
Okay.
of units there on it. But essentially, so say you draw your screening tests, renin is 4 and aldo is 18, then you do a saline suppression test, their aldo suppresses to less than 7.8. The guidelines would tell us PA is highly unlikely in that patient.
Gotcha. Oh, and I actually that's an important point though that I because you had mentioned urinary collection on this.
Yeah,
Can't
sorry.
get
So
into baseline. So
the ambulatory salt loading through diet and supplementation, what we're looking at is urinary sodium and aldosterone and a 24-hour collection. So that's why that 10 is a little bit different of a unit cutoff there.
okay. So the 24-hour urine collection, aldo under 10 is what we're looking for. And then
Yep.
if you give them IV normal saline 2 liters under 7.8 serum.
Yes. Yep. Absolutely.
Okay. Can we talk? Sorry, this is probably off topic, but I think it's come up with several times, right? If we're thinking about the question of even screening is surgery or not, like how risky is this surgery, and how effective, I guess, too. But like, it's hard for me to counsel somebody if I don't really understand the risk of the surgery, and I've never had a patient get this done. I guess I don't really have a good concept of the risk of this of a adrenalectomy.
Yeah. At KU, urology is primarily the specialty that does our adrenal surgeries here. Um, so we have some very experienced urologists who do several adrenal surgeries, whether it's, an aldosteronoma, FIO, et cetera, or MAX. Um, you know, it carries the same risks of a lot of surgeries. A lot of it's laparoscopic. The primary, the majority of patients will have laparoscopic adrenalectomy, robotic assisted. The recovery time, usually patients are out the next day. They spend a night in the hospital. There's the general, probably about 2 weeks of general restrictions that surgery gives most patients, in terms of not lifting, heavy exercise, those types of things. Um, we typically the morning after we'll check labs on patients, specifically for Max, but for PA as well. And then we'll see them back in clinic pretty quickly to repeat things. Um, you want to watch, obviously, their electrolytes very closely, their blood pressure very closely, be able to kind of adjust blood pressure medications in that immediate post-op period while they're inpatient the next day or two. And for the vast majority of patients, if you've confidently lateralized the PA, then the success rate's it's high. Yeah.
I know people really want me to go back to the challenge testing right now, so I'm going to go
Yeah.
back. Yeah. And so there's also a captopril challenge test, though, correct?
Yeah. I don't know, John, if I'm able to share my screen.
Yeah, I think you can
Yes.
you should just be able to jump in and share it.
Okay.
Cool.
Let me, because I actually have, yep, here, right here. Kind of a great graphic with the different suppression tests, because I think the visual is helpful for most people.
And just as we're pulling that up, got a comment in here about challenges that I often run into with salt loading. It's either B got very elevated or patients just couldn't tolerate the salt tablets. Besides increasing cost and invasiveness, can we skip and move directly to a CT abdomen? So I think a lot of us have a similar type of question that we'll get to, I think, after this. So
Yeah, yep, yeah, we'll definitely touch on that. So, are you guys able to see this chart?
Yeah.
yep.
Okay, perfect. This comes from the 2025 JCEM Endocrine Society guidelines on PA. So yeah, the three main suppression tests that we have: oral sodium suppression, the captopril challenge, and then IV saline. Obviously, the IV saline is going to be a little bit more cumbersome, require a little bit more resources. The easiest of these tests to do is the oral sodium suppression at home. So again, kind of running through that chart there, tell your patient to consume 4 to 5 grams of sodium for 3 to 4 days. And then on the final day is when you'll collect that 24-hour urine collection. And what you're checking is a 24-hour urine sodium, creatinine, and aldo. You're looking for a 24-hour urine sodium over 200, adequate creatinine, and then an aldosterone under. And that's where that number, sorry, Brandon, comes off on the cutoff that's specific to the urinary testing there.
Gotcha. Yeah, that's
And when
helpful.
you, yeah, and so when you have that, you're excluding PA, and so then I wouldn't go under additional, imaging, um, lateralizing, certainly no ABS. And then with the captopril challenge, what you're doing essentially is after the patient's been resting, draw baseline labs, plasma aldosterone, run in a BMP, and then you're given 50 milligrams of captopril. 2 hours later, after the patient has remained seated, you're repeating those labs and then interpreting them there in that kind of fourth column there. And again, what you're trying to see is, are you suppressing um, aldosterone? And then the saline suppression test, really similar principles. This one's done kind of, um, I actually haven't done any saline suppression testing in our lab. They've done some other endocrine testing for us where the patient sits around, glucose tolerance tests, those types of things. They probably would. I probably should check before I say that. Most patients prefer the oral sodium um, that we run into. Um, but
Yeah.
then, yeah, for the saline suppression testing, the cutoffs are there too. So,
Cool.
Perfect. Love it. Thank you for sharing.
Um,
Yeah, I've always thought like if they're on almost aren't like Cinepril or whatever, aren't they doing a Captopril challenge? Like, aren't I already challenging them? I don't know, but it's not the same, I guess.
it kind of is. Yeah,
Okay.
if you could somehow formalize the testing to
Okay.
capture that. Yeah.
Okay. This is the problem with primary care. We don't feel comfortable in wishy-washy territory. It's
yeah,
just
just
like,
tell us what to do,
yeah,
kid. I mean,
yeah.
uh,
Okay. So, we end up saying she has slam dunk hyperaldosteronism. I think you've kind of mentioned this multiple times. You have to look at the patient. You have to see if they're a potential surgical candidate. Talk to them about what that looks like. Is this a point where we diagnose hyperaldosteronism that you feel like we should be sending them to endocrine to have a more formalized discussion about everything, or do you feel like this is something that primary care can own?
Yeah, I think definitely. I mean, because as we've hit on many times in this discussion, there's a lot of gray area with the primary aldo testing. So obviously, we're super happy to kind of help jump in, give our 2 cents on the case, kind of help coordinate some additional testing if we see that that's necessary. Because a lot of the cases ultimately do fall in this intermediate gray area test. But I think from, primary care perspective, especially the more kind of slam dunk tests, the more suppressed the renin, the higher the aldo. If it's a young patient with hypokalemia, I'd go straight to the CT. I wouldn't do any suppression testing. If the CT shows a nodule that's larger than a centimeter, I wouldn't do ABS. I'd send them to urology, assuming the patient understands surgery and wants to hear a little bit more about what that's involved. Um, where it gets tricky is, the older the patient, the more likely that you have an adrenal incidentalloma anyway, and that it's hard to lateralize things. Um, I think too, kind of going back to Brandon's early point in the discussion, I think as long as the patient understands that spironolactone is likely having a very specific use case for their blood pressure and specifically will be preventing cardiovascular mortality in the long term, then I think it's fine if they understand that, they understand the lifelong nature of the medication, that you've kind of saved a lot of this additional headache with the suppression testing, the lateralizing, those types of things.
And like your point is that if they have like a unilateral focus that's hyperproductive, that is going to be a more severe form in general than someone who has like bilateral excess aldosterone production, right?
Correct. Yep.
Okay.
Yep. Large unilateral adenomas are they're ugly, they're autonomous, they're going to be causing higher aldo levels, suppressed renin, and typically in those patients, the lower potassium. Um, yeah.
Okay. And just for completeness sake, let's say in this case she's like there's two situations. There's either I want to just do medical therapy, that sounds wonderful, and then there's no, I really want this out. I hate taking medicine. So if she wants to do medical therapy, we can get away with spironolactone. But when do you push? Do you suggest that you do a Clarinone? Because I think cost for a Clarinone is a lot better than it used to be if you use like GoodRx or Cost Plus or whatever. But is that if they're a man, do you say a Clarinone is where we should start?
You know, traditionally we always reach for spiral because of the cost and availability. Um, I, you know, I if I guess I didn't realize a player was becoming a lot more readily available and cheaper.
I
If
think
that was the case,
plus are pretty affordable now.
Yeah.
really,
So okay, and then so we find a CT with adenoma, and then we send it over to IR to sample the vein. Is that
yeah,
right? To make sure that that adenoma is in fact the thing producing
right,
aldosterone? Okay.
correct. Or if you have, say you've got a 1.5 centimeter on the right and you've got a small, maybe non-specific nodularity on the left, obviously you're going to want to ensure that the adrenal gland you're going to surgically take out is the source of the issue.
Yeah.
Yeah.
Yeah, and that was a situation when the only time I've ever taken it to that level is it was a young patient. He was just we could not get him controlled and clearly hyperaldo. Like it was easy on that front, but then he had a nodule on one adrenal node, but then when we sampled him, it was bilateral, and it kind of just
Yeah.
shot the whole thing. And so, we've ended up kind of titrating up a Clarinone actually on him.
Yeah.
But I've never got to the stage of getting them to surgery, I guess. But um,
For Max, it's a little bit different. Um, with PA, because we have such easy and readily available medical therapy, why put a patient through a risk of, taking out the wrong adrenal gland unless you're, very, very confident that that's the source of the PA. Max is a little bit different of a situation. Sometimes, depending on the different type of adrenal nodularity, surgeons will take out the larger adrenal gland. And for the vast majority of patients, that's successful. Now, there is AVS testing for cortisol and for Max as well. And so that we'll do that sometimes. That's even more less defined than PA. So it's difficult. But yeah, for PA, because medications are so readily available and commonly used, unless you're confident about it, the surgeons won't take it out. So
yeah,
Cool.
okay,
Yeah, I looked up a Clarinone. It's $25 for a 90-day supply. So
yeah,
for $100 a year. I mean,
yeah, that's not bad.
I would definitely do that. So, okay.
Yeah, this is helpful. Any other questions from the group? Sorry, we got created a little bit of confusion, I think, with the chat and the Q&A. We'll get that ironed out next time. But uh, yeah, I think just really helpful all the way around. One question, I guess, is logistically, are you guys doing any e-consults in endocrine, Kyle, or have you guys talked about that?
we aren't currently. Yeah, unfortunately. Yeah,
Yeah, that would be huge. Neurology has done that for us for these Alzheimer's workups, and it's a really helpful kind of game changer on this sort of stuff. And so, just a plug for your division if you guys ever want to tackle a new project, we would use it, I think. And I think this is the area, and many others in endocrine that would be just sometimes we just need an extra set of eyes or just, looking through the data and making sure
yeah.
that we're doing this in the right way. And so, just that's just something. I think that's the future of a lot of this stuff.
Yeah.
I do too. I think that's a great point. And, just giving a little bit of input on some additional testing,
Mhm.
that the patient can just get started on even before they necessarily meet with endo. So,
Yeah.
yeah.
Okay. Do you have anything else?
Okay. I don't think so. No,
Okay.
this was
Really
Well,
helpful.
very helpful. Yeah.
hopefully it's not more confusing than when we started. I know sometimes
No,
adrenal endocrinology can be that way sometimes.
yeah.
Yeah.
No, this is great, Kyle. Thank you so much. Super helpful. Thank you for the questions in the chat, and we will see everybody back in a couple weeks.
Yeah.
Okay.
Yeah. See you in a couple weeks.
All right.
Thank you for having
Sounds
me.
good.
Thanks
Appreciate it.
again. Bye.